Hello again. I'm Colin Brown. I'm one of the course directors for our Allied Digestive Health Conference in managing chronic GI and liver disease. I'm joined today by Dr. Robert Brown, who is putting the liver into our conference. And today we're going to recap his excellent talk. We reviewed approaches to metabolic-associated liver disease. And we're going to recap this discussion and hopefully have a few take-home points. So, Dr. Brown, thanks a lot for joining us. Thanks for being here today.
Thanks, Dr. Brown. I like it. It's Brown and Brown.
Yeah. We could start our own accounting firm or law firm or just maybe be a couple of gastroenterologists.
There you go. No relation.
Fatty liver, right? Metabolic-associated liver disease. I mean, as you mentioned, it is an ocean of patients out there. And you could do just seeing fatty liver patients all day for, every week. How as gastroenterologists do we better discern and narrow down the patient pool to ones that actually demand a higher level of attention?
Yeah, I mean, I think we have to start to educate primary care providers. First, I guess we have to educate ourselves on how to use non-invasive tests that are commercially available to figure out who has significant liver disease from those who have metabolic risk factors but don't have significant liver disease, who still need attention but not from a gastroenterologist. I'm sure most of our audience, as well as you, every week are getting people who have fatty liver on ultrasound because they either had mildly abnormal liver tests or because they had right upper quadrant pain or some other abdominal pain and got an imaging test. I even get those that have fatty liver on a cardiac CT and have completely normal liver tests. So I think we have to get those non-invasive tests that are available into clinical practice, starting with FIB4, which is available on every person that you get a platelet count and a hepatic function panel. And we can calculate a FIB4. And once again, as I said, if it's under 1.3, I think we can feel safe that that patient should stay in primary care practice. If it's above double that, say 2.6, clearly in GI, and then in between is that indeterminate zone.
So, great. Patient has a fatty liver. They come into your office. You run the FIB4. You find out that the FIB4, 1.8, we'll say. What's the next step?
So I think the key is in both those with an indeterminate test or who have a lot of metabolic risk factors, a secondary test should be done. And I divide those into blood-based tests and imaging-based tests. So for the blood-based test, you have the NASH FibroSure and the Enhanced Liver Fibrosis or ELF test. I tend to use the ELF test because it has, one, it has more gradations, and two, it doesn't require you to fill out a lab slip with their BMI and the presence or absence of diabetes. But either one works. NASH FibroSure through LabCorp, ELF through Quest, or an imaging-based test, of which obviously FibroScan is the most used and highest validated, but you have ultrasound elastography or ARFE, acoustic radiofrequency, and MR elastography, which the advantage of ultrasound and MR elastography is they don't require the equipment. They can be ordered from any radiologist who performs it. And I'm seeing ultrasound elastography on more of my reports for ultrasounds that get sent. I don't know if that's true here too, but
I get a smattering of them, but not consistently.
And so that should take the patient, 90% of the patients, and then rebucket them into either a low-risk category, once again, back to the endocrinologist, cardiologist, PCP, or those with F2 or above fibrosis who should at least be followed in conjunction with a gastroenterologist, hepatologist.
So, as you know, part of our job is just discerning through the buckets of data that come towards our desk. And many times you'll get discrepancies. You'll have a test that may indicate that there's not much in the way of worrisome disease. And then you'll also get another test that shows that possibly this patient has an elevated risk for advancing liver disease. What do you do when there's that discrepancy?
Well, I think first is those patients probably do need consultation with GI hepatology. We can't expect our primary care doctor who has to manage hyperlipidemia, diabetes, obesity, and then also try to interpret discrepant tests. I think getting the primary care doctor to order the tests, and then if there's discrepancies, I use my clinical judgment. Is the liver nodular on imaging with a low platelet count? That patient has cirrhosis. Are they, young and have a completely normal imaging, but they have a very high ALT, which will raise their FibroScan score? And so I think you have to use your clinical judgment. And I think this is one of the times where fighting for the MR elastography is worth it. I don't think MR elastography has a lot of false positives and negatives. And if you use MR elastography in those rare instances where the tests are all over the map, I think you won't have to biopsy a lot of patients. But every once in a while, I have one test that shows cirrhosis and others that don't. The patient needs to know. And I think we have gotten away from liver biopsy so much to a point where now we're reluctant to do liver biopsies when it's needed. I have a patient who has mild risk factors for fatty liver, but a strong positive ANA and liver tests that are really too high. And I cannot convince her to have a liver biopsy to rule out autoimmune hepatitis because her GI said it's a very invasive test. So I think there are times we need to do a biopsy, particularly if there may be two things, or if we really feel like we have discrepant tests. Because telling a person, well, I'm just going to do liver cancer screening for the rest of days to avoid doing a liver biopsy, to me is too much.
No, I agree. I think especially when you're talking about long-term surveillance, endoscopic screening for varices, ongoing HCC surveillance, and MELD labs every 6 months to a year, it is important to make that distinction.
By the same token, you don't want to miss a patient who has advanced fibrosis and then have them come back 5 years later with no screening with a large HCC.
Well, and one of the benefits, from my understanding about the FibroScan, is that its positive predictive value may have some issues, but the negative predictive value is very good, right? So you're not as likely to miss advanced fibrosis.
Yes, I think you have more situations where you overstate. The patient ate. They have very high ALT. Fat can also read as stiffness. So yes, I think if you have a FibroScan below 8, you can feel reasonably reassured that it's fine. I haven't missed a lot of patients that way.
Yes. So we'll move this discussion forward to the more management and therapeutic area. So we get our patient. He has the fatty liver. We do the non-invasive testing. We confirm that there may be some degree of fibrosis. We'll say F2 or F3. In that situation, where do you go from there? We now have some therapeutic options that haven't been there. We also know that it's at its essence, it's a metabolic disease. And these are factors that need to be managed. When this patient comes to your office after having that information, after having that data in front of you, where do you take the conversation?
Well, I think I like to start with the fact that we have, for the liver disease, which at the end of the day, that is my management job, right? I am a liver doctor, a gastroenterologist. My job is to manage liver disease. I have to tell them we have one FDA-approved treatment for NASH or MASH with fibrosis, and that is resmetirom. And that's been shown to reverse NASH and regress fibrosis in a considerable portion of patients. At the same time, we need to manage metabolic risk, because even if we regress fibrosis, It would be like regressing fibrosis and not curing Hep C. We need to do both. And which order you do them in really depends in part on what's the low-hanging fruit, and two, what's the patient motivation, and three, how much fibrosis. So if someone has F2 and a hemoglobin A1C of 12, maybe manage the diabetes first, because I don't like to start a GLP-1, for example, and resmetirom at the same time, because the GI side effects are heavily overlapping. But if they have pretty well controlled, or they've been unable to lose weight despite multiple attempts, let's deal with the liver disease and the liver fibrosis first and give us a longer runway to manage the metabolic risk factors. So I don't think, people ask me at many of my lectures, should I start a GLP-1 or resmetirom? And the answer is, to me, is, do they need a resmetirom? Do they need a GLP-1? Or do they need both, which many people do? One is indicated for obesity and type 2 diabetes. One is indicated for NASH with fibrosis. And if you look, even if you want to look at the preliminary data for GLP-1s in NASH, you only get about a 20% response rate. I think a lot of our patients are going to need multiple medications.
And that really gets to the heart of what advanced metabolic-associated liver disease is, right? It's really it requires a multi-specialty approach, multidisciplinary approach to this problem, because there are so many other factors at play. There's cardiovascular health, there's metabolic health. So we need to include the primary care physicians, the endocrinologists, and even the cardiologists.
Yeah, I mean, we're just getting away. Our prior liver diseases were relatively simple. We cured Hep C, we managed Hep B. When we get into alcohol and metabolic-associated steatotic liver disease, there are behavioral components, and we are either going to have to manage them ourselves or more likely manage them as part of an integrated care system, because the burden of both alcohol and metabolic steatotic liver disease will overwhelm us as gastroenterologists if we have to manage everything. So I try to focus on managing the liver disease, stressing the importance of risk factor reduction. We have to be part of that solution, but we can't enact the solution, just as we can't expect the primary care doctor to manage cirrhotic patients and their HCC screening.
So we had the discussion. We're now looking into starting a medication. When a patient is to start resmetirom, what do you tell them? What do you tell them to expect? And how do you manage that patient going forward?
So, I think the important thing is to tell them what to expect and what not to expect. So what they can expect is about 20% will have GI side effects, and those are usually nausea and diarrhea. Usually mild, but for some people, nausea is never mild. I hate nausea. And so the key is that it occurs early. It's usually manageable, and it actually usually resolves even if you continue the drug, because no one's going to take a medication that's going to cause nausea for the whole year. That's unreasonable. But in the clinical trials, it tended to resolve. Now, obviously, patients who have ongoing, unremitting nausea probably stop. But the other thing is to tell them if they don't get the nausea and they make it out to a month, it's not likely to happen, and that we'll try to manage it. And if we can't, we won't. But the second thing is what not to expect. This is not a weight loss drug. Many people are associating dealing with MASLD or MASH that they're going to lose weight. It doesn't. There's no weight loss. It has a salutary effect on lipids, but not on anything else. Their hemoglobin A1C is not going to get better. That has to be managed concurrently. And then the last thing is that they have to know, and you have to know, that the liver tests tend to increase at week 4. So if you're going to measure a week 4 ALT, You have to prepare your patients because they get the lab test before you do half the time, that not to panic. Or don't measure it at week 4. Wait till week 12. And then the last thing is that the FibroScan will not improve in the clinical trials for a year. So try not to repeat that till a year, or else people will be discouraged.
So back to FibroScan. After you started the patient on the medication, a year does go by, assuming their liver tests either stay the same or maybe even improve. Is that when you would look at the liver again with the FibroScan, and how would you interpret that information?
So I think at a year, I do repeat my elastography. If I have an interpretable FibroScan, a patient who's markedly obese, who I haven't been able to get a good FibroScan, MRE. The ELF should also get better at a year. And so I think you can do any of those. To me, if it's the same or better, I'm going to continue. If it's worse, I think we have to think about what are we doing wrong? Is it that we really need to add a medication for the metabolic factors? Is it that they're not taking it? Or is it just not the right drug for them? We don't know what made those 30% good responders, and then some who responded but didn't meet the primary endpoint, and then there were some who didn't get better. And so I think at that point, if they get worse, we have to either stop or add. If they're better, we continue. And I don't know, we don't yet know, because that trial is ongoing with patients still on resmetirom, what the real endpoint is. But I think in my clinical practice, if they got back to F0, F1, I would say they no longer have an indication. I guess I'd stop then.
I guess at that point, you can reset the clock.
Right. And then hopefully manage their metabolic risk factors, or else it'll be. But, if you think about it, in so many of our diseases, that is what we do, right? You put in a cardiac stent, you ask people to not smoke and eat better. Some of them do, and some of them need restenting. And I think we may find for MASLD and MASH that we reset the clock to the best of our ability. We try to slow the reprogression, but there may be patients who need continuous or intermittent treatment. And I guess we'll have to learn to accept that.
Well, I think one of the things we're always trying to do as doctors is, number one, retreat the disease. But number two, promote health the best we can. And we can't, as you said, we can't do everything, but we do our part when they're in front of us and try to remind them of some of those easy things that we know about that can help them live a better lifestyle. To that end, any low-hanging fruit that you would suggest from a lifestyle standpoint, incorporating that into the discussion with fatty liver disease?
Yeah, I think you have to feel comfortable discussing things that many of us don't like to discuss. And one of them is alcohol. And so if somebody's getting worse, think about alcohol, because alcohol and metabolic factors can go together. Their weight, they can't hide. Their hemoglobin A1C, they can't hide. The alcohol, they can. I think you have to have a frank discussion about drinking. I talk a lot about what one standard drink is, and that the safest amount is 0, but if not, keep it to 1 standard drink per day. And I always throw in, you can't save them all up for Saturday night. Talk about binge drinking. And then I think we underutilize the measurement of PEth in our clinical practice. PEth, or phosphatidylethanol, whatever it's called,
yes,
is commercially available. It measures alcohol use over 2 to 3 weeks. And we think of it somehow as like a punishment, or having a drug test to get into the Olympics. But I tend to say to my patients, it's like hemoglobin A1C, but for alcohol. And if you have a high PEth, our goal is to bring your PEth down. And you can use that number to really be a better set on what you're drinking and how to reduce it. And if you're not judgy about it, I think you can make progress. So if their PEth is 600 and they get it to 300, you're like, hey, you're making progress. You reduce your alcohol intake by 50%, and now let's try to get it to 150. And each of those steps will go a long way. And then I talk a lot about what people shouldn't eat and what they should eat. And, the sugar-sweetened beverages, high fructose corn syrup, the things that we love to eat really are bad. And I tell them how high fructose corn syrup goes directly into the liver and turns into fat. And because it's not recognized by the body and it gets outside of our circles. And so we should try to avoid that. And if you eat things that are fresh, more vegetables, more good fats like avocado and olive oil, things that are actually quite delicious, you can have a healthier life and live longer.
It is interesting because when patients hear fatty liver, the first thing they think they need to reduce is fat, when in reality, it's the sugar.
Yes, and you have to have that conversation. We don't have time to have a detailed discussion. If they need a nutritionist, have them go to a nutritionist. It's a good investment of their time, and even if they have to pay for it, their money. But yes, it's true, because most low-fat foods are high in carbohydrates because that's what they replace the fat with. And so I talk about good fat foods. Because the other thing you want to avoid is people want to go on these sort of very keto type diets where they eat bacon and eggs and no carbohydrates. And one is no anything is generally not good and also so unsustainable. Yes, you'll lose weight on an Atkins type diet, but you will never maintain it because the minute you put the carbohydrates back in with all those bad fats, right, you're going to just regain your weight.
And that's the appeal, I think, of the Mediterranean diet, because as you had mentioned in your talk, people live on the Mediterranean diet. It's a way of eating that can be sustained over years.
The other thing is I also like to give people numbers. I think people respond to numbers. And I tell them that 300 calories out of your diet per day will result in a 1 pound per week weight loss. And so then they don't have to think about how many calories they are eating. They just have to think about, well, what's one thing that's 300 calories I can take out of my diet? It's a good place to get to alcohol because many alcoholic beverages right there at that 300. Drop one and you're there. Or for some people, it's that late night snack, the Pepperidge Farm cookies. The big ones are 300 calories. I love them. But if I wanted to cut 300 calories, maybe it would be that, only doing that once a week instead of every day.
I see, at the risk of making a bad pun, you really make this approach to weight loss digestible.
I like that. I'll have to use that in my lectures.
So we'll just a few more things. You had touched it in the talk. We do have a therapy that's approved for people with F2, F3 fibrosis. Obviously, decompensated cirrhotics are a category unto themselves. What do you do with the compensated cirrhotics who have this condition?
Well, there are, resmetirom is in an active clinical trial for cirrhosis. We'll await the results. One would hope that it will work in compensated cirrhotics. I think the first thing we have to remember for compensated cirrhotics, and maybe those with advanced F3, is the need for HCC screening. That for the compensated cirrhotic is the biggest threat to their life, and we need to make sure we do that. And I tell them visiting me is important, but getting a scan twice a year, that's life-saving. If you miss an appointment with me, nothing bad's going to happen to you. You miss your scan, so I go through it. It's like, this is September, so every September, every March, you need to have a scan. And if you collaborate that with the primary care, so they're seeing you in September and the primary care in March, and they know scans and labs at those 2 times, that's important. So cirrhotic healthcare maintenance. And then I think for them, metabolic control is all we have right now, and the hope that other therapeutics will get there. But the need for that metabolic control and hope that maybe a GLP-1, if the hope that they would work off-label for NASH, would be the only options you have.
So to wrap it up, as you're somewhat alluding to, there are some trials and some agents that are being studied. As you look on the horizon, where do you see the therapeutics going?
I think that this is a complex disease with cardiometabolic and liver disease. And I think we're going to use combination therapies. And obviously, we're going to be heavier on the cardiometabolic for early stage disease and heavier on the antifibrotics for late stage disease. And I guess in the middle, we'll use both of them. But I think most of these multifactorial diseases, we certainly, even single disease like diabetes, no one's on just one drug anymore. Similarly for antihypertensives. So we'll need to look for mechanisms of action that are at least complementary, hopefully synergistic, to make sure that we can deal with this rising tide of steatotic liver disease.
Well, Dr. Brown, thank you so much. It's always a pleasure talking to you. It's always a pleasure learning from you. And while I won't see you at the family reunion, hopefully I will see you at other conferences just like this.
Well, maybe we have to start a Brown and Brown family reunion. We'll meld our two families. But thank you for having me.
Absolutely.